So the talk today is about LAA occluders, the right device for the right patient. So it's pointing. So there's two questions to answer here. First of all, when to implant an LAA occluder device? And the second thing is which device to implant if there is such a difference between devices. So regarding the rationale for using LAA occluders, as you all know, the use of LAA occluders has become more frequent in the last few years, and it really has a little niche in the world of interventional cardiology and the management of atrial fibrillation, thromboembolic risk protection. Most patients still will receive oral anticoagulant drugs. And then there's a few patients that will receive LAA clips if they go to surgery, and then surgical ligation, and there's some LAA clip being produced commercially for use. We'll talk a little bit about one of the devices, but most of the current devices used are really endovascular LAA occlusion devices. So moving on. The risk of developing stroke in patients with non-valvular atrial fibrillation is significant. It's about 12.6% of patients in one study that looked at patients who underwent surgical intervention to their cardiac surgery, basically, and these patients had 12.6 incidence of percent incidence of the left atrial appendage clots or left atrial clots. Now 90% of these clots were found in the left atrial appendage, and only 10% were in the left atrial cavity. Modalities we use to treat them are vitamin K antagonists, are the commonest, of course. However, these are flawed with problems of basically patient compliance, bleeding problems, and also 67% risk reduction. So there's still quite a few patients that are not well treated with these medications. Surgical excision of left atrial appendage, of course, is invasive and is only done in patients who are actually undergoing surgery for another reason. And there is some recurrence. There's residual shunt in 10%, so it's not perfect. So a transcatheter device closure does have a place. And if you compare the NOACs to Coumadin, we've had an earlier talk today was clearly demonstrating that these medications are at least non-inferior, if not more efficacious than Coumadin, with less overall mortality as a group. Safety is generally safer. They definitely have much less intracranial hemorrhage, but more GI bleeds with some medications more so than others. And there's concerns about these drugs. Number one is no antidote for emergencies, although this is going to change in the near future. And there's contraindications in patients who are end-stage renal disease. These patients cannot use such medications. And also with Coumadin, these patients, the only medication they can use is Coumadin, but actually they still have a high risk with Coumadin. The gaps in oral anticoagulant therapy occur in patients who have bleeding problems and basically patients with end-stage renal disease where the risk of bleeding is high and you only can use Coumadin, and these patients frequently have problems with their INR being difficult to control. Patient compliance with medication is another issue, and of course the incidence of thrombus even on oral anticoagulants is not zero, so there is room for improvement. Now, the current guidelines, ESC and ACC AHA guidelines, both give this device technology a class 2B indication with a level of evidence B. So basically it can be placed, it can be considered as a modality of treatment. So which patients should we look at as potentially appropriate patients to receive the device? Basically, in summary, patients who have had recurrent ischemic stroke despite well-controlled therapeutic oral anticoagulation. So these patients who have failed oral anticoagulation, patients with previous intracranial hemorrhage, these are a high-risk group of patients where you may not want to try further anticoagulation with even the oral anticoagulants, the newer oral anticoagulant therapies. Recurrent GI bleeding is a big problem, especially in places where it cannot be fixed, such as a small bowel. These patients continue to become challenging in their management, and the left atrial appendage occlusion device may actually be an ideal device for this group of patients. Other comorbidities such as uncontrolled hypertension, cerebral microbleeds, these patients again pose a higher risk of cerebral hemorrhage or bleeding, and the device may be considered in such groups. Of course, patients with coagulopathies or bleeding diaphyses where they have a high risk of bleeding, and intolerance to the newer medications. Of course, they cannot be used in patients with end-stage renal disease, and as we mentioned earlier, the end-stage renal disease patients do form a specific group that is a bit more challenging to treat, and these devices may be best in these cases. So now, after identifying the patients that we need to treat, which device should this patient receive? Let's start off by looking at the left atrial anatomy. So the left atrial anatomy has been described in multiple series with different terminologies. But in this series, basically, they classified into 4 groups the shape of the left atrium, the morphology. This was done using multimodality CT and multi-detector CT scan, and they classified them into 4 groups. The first was the windsock group, which is basically a long, elongated shape of the left atrial appendage. And then you have the chicken wing, which involves an acute curvature of the left atrial appendage. Then you have the cauliflower, which is multi-lobed, and then the swan. And they looked at the prevalence of these appendage morphologies in normal population of almost 200 patients. And the windsock was the commonest, about 40% prevalence. Second was the cauliflower, about 30% prevalence. And then about 20% for the chicken wing and 10% for the swan. I think the other modalities that have been described, the broccoli and cactus, they're probably variants of this form of left atrial appendage morphology. So the types of the LA occlusion devices we currently have in the market, there's quite a few, and the technology is being developed and refined, so it will get better. So the commonest ones, well, first one that came out in man was the Plato. This was the first one to be used, and it really proved the point that this is a feasible technology and can be done, and it was successful. However, this is no longer being produced and it's no longer in use, the Plato device. It's formed of a nitinol frame with PTFE meshwork, and then it deploys itself into the left atrial appendage. All of these really basically are nitinol based. They're all endovascular except for some I'll show in the next slide. The next one is the WATCHMAN. This is the most commonly used one. And the third one here is the Amplatzer cardiac plug or the Amulet. And again, same kind of principle, occluding it from inside. The LARIAT is one of the examples for the external occlusion or basically surgical clipping almost like of the left atrial appendage, where you have a loop or a lasso that comes out and actually clips and separates the left atrial appendage at its ostium, and I'll talk a little bit about that later. Another couple of examples of endovascular devices are the Lamber and the Wavecrest, and these really haven't quite made it up to the market yet with ongoing studies and evaluations. A little bit about the WATCHMAN. Basically, it's a self-expanding nitinol frame with fixation anchors and a permeable fabric cover. There's 5 sizes available, 21 to 33, and it's usually implanted by transseptal approach using a catheter-based delivery system. Of course, it allows for retraction and recapturing the device before we deploy it eventually and finally when we're happy with the position. It received its CE mark in 2005 and US FDA approval in 2015. This is some of the autopsy findings. The first 2 on the left are canine models at 30 days showing endothelialization and complete endothelialization by 45 days of the device. This is a human pathology where a patient died for some other reason, and this was 9 months post-device implantation. You can see it's nicely covered and endothelialized. So the WATCHMAN device really is the only device with large numbers of patients enrolled in prospective randomized clinical trials. So this is it's really the prototype device right now for this procedure. And implantation success rates was noted in 95% of these patients, high rate of success. Efficacy at 4 years, the WATCHMAN was noted to be superior to warfarin in primary efficacy, which included a combined endpoint of stroke, peripheral emboli, and mortality. And then also superior in terms of all-cause mortality, which is really the hardest endpoint in clinical medicine, as well as superior in cardiovascular death. So definitely better than warfarin as a treatment option for patients with non-valvular AFib. Safety-wise, procedural related complications occurred in 4.1 to 4.4% of patients. Initially, with the first trial that came out, the Protect AF, the incidence of complications was a bit higher because the learning curve was about 8% or so, and then it got down to 4.1 to 4.4%. So the WATCHMAN device is now indicated by the FDA for use in patients who have an indication or are suitable for warfarin use, but also should have an appropriate rationale to seek a non-pharmacologic alternative to warfarin. And this is just to justify the risk of the procedure. Now, advantages and disadvantages of the warfarin device, of the WATCHMAN device, sorry. It's definitely superior to warfarin by clinical trials. It has the largest body of evidence, and it causes reduction in all-cause mortality, which is really a very hard endpoint. Disadvantages, the device does have a potential for embolization if it's been undersized. The depth of the device equals the diameter, so that if you have a shallow appendage, you really can't use the device in these patients. So there are some limitations in terms of anatomic morphology of the left atrial appendage. And also it requires anticoagulation for 6 weeks to allow endothelialization. After that, you switch from Coumadin to antiplatelet therapy for a combined total of 6 months. So if you do need to get off anticoagulant or antiplatelet therapy very quickly because of bleeding concerns, that might be a hindrance with the WATCHMAN device. Coming over to the ACP or Amulet device, basically it differs from the WATCHMAN in the sense that it has two structures. The first structure is the lobe, which anchors the device in the left atrial appendage at the neck. And then the second structure is the disc, which covers the ostium of the left atrial appendage. And between the two, there's a waist. And again, this is all nitinol, which makes it flexible. And this waist allows for seating and positioning of the left atrial device to suit itself to various anatomies. There is some flexibilities here where you can have different angulations between the neck and the ostium of the left atrial appendage. And therefore, this waist gives it room for wiggle and repositioning and reseating. So it's a very nice device in that sense. Similar to the WATCHMAN, it has anchors that fix it to the left atrial wall, and basically overall it has a bit more flexibility with sizes compared to the WATCHMAN device. The sizing, however, is a bit different in this device. When we come to size this device, we use the landing zone, which is about 1 centimeter inside the ostium. So you measure the ostium, and then you take a point perpendicular to the ostium 1 centimeter into the left atrial cavity, appendage cavity, sorry, and that's going to be your landing zone, and that's what you need to measure for sizing of the device. So this is the ostium, this is the landing zone, and this is the depth of the appendage. The good thing about this device is that the depth is fairly fixed, whereas in the WATCHMAN device, you do have the width of the diameter of the device equals the depth of the device. Here, the depth is fairly fixed. For the first 4 sizes, you need a depth of 10 millimeters or more. For the larger 4 sizes, you need a depth of 1.2 centimeters or more. So really fairly shallow depth to allow for anchoring of the device, and then the ostial portion is sealed off with this disc. Regarding the implantation success rates, fairly similar to the WATCHMAN, 95 to 97%. Efficacy, this device does not have prospective randomized controlled trials, so it does not compare the device to patients on Coumadin. It's basically registries where it's being compared to patients who are not able to take Coumadin. And the success rate of reducing stroke, basically 63% relative risk reduction in stroke versus expected according to the CHADS-VAS score, and 60% reduction in bleeding versus the expected according to the HAS-BLED score in the population. So fairly efficacious. Safety profile, again, similar, maybe slightly higher numbers as compared to the WATCHMAN, 4.4 to 5.7% combined stroke, embolization, or tamponade. Device embolization occurred about 1.5%, and same with tamponade. So I think these numbers can also be improved with operator proficiency and as the device gets more commonly used. Looking at the advantages and disadvantages of the Amulet, it has the widest range of left atrial appendage coverage by size and morphology because of the way it's structured, and comparable to WATCHMAN device in terms of efficacy and safety. Now, it does not have any prospective randomized trial data. Again, like the WATCHMAN, it does have a potential for embolization, and you do need dual antiplatelet therapy for 6 months following the procedure, but no Coumadin. I'm going to talk a little bit about the LARIAT devices, a little bit different. The LARIAT device is a device that requires both transseptal access and percutaneous access through the pericardial space, the normal pericardial space, which has little fluid. So it does carry with it the risk of entering the pericardial space, which is usually commonly done these days by electrophysiologists who are doing epicardial ablations. So this device actually was FDA approved and CE marked for suture delivery. It's a suture delivery device. It was not really FDA approved for LAA occlusion. It was never really studied for that reason. So basically the studies that are available right now are kind of registries, retrospective stuff, comparing, again, in patients who are not amenable to using Coumadin or anticoagulations. It has two components. There's a magnet actually in both the endocardial and epicardial wires that come out to meet together at the tip of the left atrial appendage. This is from the inside through transseptal puncture. This is from the outside through the pericardial puncture. This magnet from the inside has a balloon catheter just behind it, and that balloon catheter allows us to identify the ostium of the left atrial appendage by fluoroscopy, and then the magnet's going to be distal to it. The two magnets kiss at the apex, and the loop goes in over the wire through this, and it basically clips the left atrial appendage. So this is what it looks like. Orifice is here, left atrial appendage is here. These meet at the distal edge, and then you lasso the left atrial appendage at its neck, and then you basically tie it there. You deflate the balloon, you come out with this system, and then you come out with that system. So a little complex, involves dual access. And regarding to the implantation success rates, well, of 100 and I think 19 patients that were studied in this one trial, 13% of patients had inappropriate anatomy from the get-go because of the way the left atrial appendage was positioned or the size. Another 3% had pericardial adhesions after they were attempted. So after the procedure was started, there was pericardial adhesions that precluded from proceeding with the closure device. And then eventually attempted in only 75% of eligible patients. That's what happened. Basically 96% successful implantation rate in those that were attempted. Efficacy is a difficult number to basically come up with, but basically from that trial, around 18% of patients had leaks up to 1 year post-procedure. So even after they closed it, some patients did develop leaks later on during the course. And finally, regarding safety, the number I record here is from this one trial. There's really a little bit of a paucity of evidence here on this device, a 3% complication rate, but this is from a single center, probably a center with a high rate of patients undergoing epicardial ablations, probably operator proficiency. Just looking at it, comparing it to complications rates in epicardial ablations are 7.7%. So 3.3% is a highly proficient center. I don't believe this number. So basically, this is a skewed number and should not be relied on. Generally speaking, it involves 2 accesses and 2 sets of complications with these accesses. So it's not going to be less than the other devices. Pros and cons, there's no risk of device embolization compared to the other 2 devices. It allows for immediate post-procedure cessation of anticoagulation or antiplatelet agents. So after the procedure is done, you can actually reverse a heparin and get done with this anticoagulation business. However, this advantage requires both transeptal and pericardial access. It's limited by LA anatomy, needs a CT scan prior to the procedure being scheduled to define whether the anatomy is suitable or not. It's limited by patient profiles, which I'll discuss in a second, and then it's not FDA approved for LA occlusion, and recanalizations and leaks have been reported. Patient profiles that are not suitable for the LARIAT include history of pericarditis, history of cardiac surgery, pectus excavatum, recent myocardial infarction within 3 months, and history of thoracic radiation. And anatomically, we're talking about LA with more than 40 millimeters of contraindication. Certain anatomies like superior direction of the left atrial appendage or bilobed or multilobed appendages are a problem as well. So there's a recent warning from the FDA that came out, I think, last July regarding this device, saying that there's been 45 adverse events that were reported through June 2015, and 34 of those, meaning 75% approximately, resulted in the need for performing emergency heart surgery. That's a high percentage. So there's a warning to the physician saying that you should be aware that safety and efficacy of the LARIAT has not been established in patients who have non-valvular AFib. So finally, getting to the question, which device to implant in our patient? First of all, I'd say for now, we have to stay away from the LARIAT. The evidence is very hazy, and the complication rates are probably higher than what was determined here or noted here. Regarding the other two devices, this is a nice, elegant study that looked into CT scanning. This is actually the same study that we showed the anatomy in. Basically, looked into the geometry of the left atrial appendage, and through that they assessed the feasibility of endovascular device implantation based on multimodality CT scanning. And they looked at both WATCHMAN and the Amplatzer cardiac plug, and according to the sizes that they can close from the measurement of the diameter, maximum ostium diameter, which is what you use to measure for the WATCHMAN device, 80% of normal patients usually can get the device closed. When they looked at the perimeter in these patients, that number increased to 87%. They basically assess the perimeter as opposed to just a single diameter, and that gives us more inclusion of patients. So 87% can be covered by the WATCHMAN device. Regarding the ACP, the numbers are 84% and 92%. And regarding both devices together, if you choose one or the other, you can cover 99% of anatomies or appendages. So just to get to the bottom of this, comparing the two devices, the WATCHMAN does have both. Yep, I'll just take 30 seconds if the panel allows me. The FDA has, the WATCHMAN has both FDA and CE mark. The Amulet only has CE mark. The WATCHMAN is the only that has randomized controlled trials. However, the WATCHMAN needs 45 days of anticoagulation. They both need up to 6 months of anticoagulant antiplatelet therapy. The WATCHMAN covers a bigger range of, the WATCHMAN covers a smaller range of left atrial appendages, but and basically because of the diameter size and because of the depth that it needs. Remember also not to implant devices in patients with valvular AFib, of course, in the presence of intracardiac thrombus and active endocarditis or other infections producing bacteremia, and where placement of the device would interfere with any other intracardiac structures. Finally, I want to summarize by saying that most patients will still be treated with oral anticoagulants. For those who are unable to use oral anticoagulants, or who fail treatment with oral anticoagulants, or who have a high risk of bleeding, the percutaneous LA occlusion basically gives you a great alternative for stroke prophylaxis. Procedure risks and benefits should be outlined to the patient, and device choice should be based on left atrial anatomy and size. Amongst the currently available devices, I think the LARIAT really should be avoided at this point in time because of the complications we mentioned earlier. And amongst the intraluminal obliterating devices, the WATCHMAN has the largest body of clinical data with superiority compared to warfarin and reduction in all-cause mortality, while the ACP or Amulet has the largest range of possible anatomical coverage with established safety and efficacy but lacks randomized clinical data. Thank you.